an aquifer case. I've mapped each of those to an aquifer case so that as I am monitoring the students' patient logs in XSAT, at the end of the rotation, a couple days before the end, I'll see to make sure that they've seen and logged all of the must-see cases. And if they haven't, I will send them the aquifer case that corresponds for them to complete. And as was mentioned earlier, the cases take between 30 minutes and an hour for students to complete, depending on how engaged they are. So you want to give them enough time to complete. Generally, family medicine students may miss one or two of the must-sees, so not really too big of a deal. The other thing, though, is the hour minimum. We require students to be in clinic seeing patients with their preceptor a minimum of 30 hours per week in our 5-week rotations. And so if the student's preceptor calls in sick or cancels a shift, or the student calls in sick, I can actually use these cases to shore up the time remediation as well. So that's actually a really good thing. I know that we talked earlier about, you can see at the bottom there, I've got it's really small, but you can see the student's completion of the case, which with the green circles and the check, and then the ones that they haven't completed with the red dot. So that is just sort of a screenshot of the family medicine cases. I will say that if the student misses more than one shift or a couple days in clinic, we don't use aquifer cases to remediate that. They do have to do a clinical experience. So just here and there pieces are a really good way to remediate. So the second pearl is knowledge and skill remediation. And I use an example here because I particularly like this case in aquifer. So if the student's case log for diabetes management, which is one of our learning outcomes, be able to address diabetes management, their case log doesn't mention a diabetic foot exam or a referral for a diabetic foot exam or something about that piece of preventive care for diabetes, or if their student performance report on the end of rotation exam notices that those are the topics, or that's a specific topic that they have needed some remediation in, I will assign a case that corresponds to that. So this case on diabetes in aquifer actually has a video and explanation of a diabetic foot exam. So the student will, as we've engaged in discussion, either on XSAT, I type feedback in XSAT, I noticed that you're missing a diabetic foot exam, can you tell me a little bit about this if they can't, or in meetings, remediation meetings after the exam, if they're unable to explain, I will assign this case to complete before they retake their exam. So there are many, many examples of different cases, different outcomes. Again, being familiar with the cases, you can use that search function, look up your outcomes, look up the cases that correspond, go through the cases, make sure that they meet your outcomes, and you can sort of keep that reference to send out to the students as you need it. So next pearl, next slide. So my pandemic pearl, the clinical rotation hiatus that we've all been experiencing. So what we have done is we've created mini remote rotations, MRRs, not to be confused with MMR, but MRRs. They are a 1-week rotation that is really like an intense boot camp of learning, kind of like a board review. So we have specific goals, objectives, a syllabus with learning outcomes that mini micro map to the regular course syllabus for the family medicine rotation. And you can see kind of a schedule here on the left-hand side there. That is our suggested schedule for the family medicine MRR. So we've incorporated several aquifer cases that they do a few cases per day. I've incorporated some other self-study modules that I've used online before, the dermatology cases from American Academy of Dermatology, the Smiles for Life, oral health curriculum, etc. We're all familiar with those tools, so that at the end of that week, they have gotten a good overview of the general family medicine topics that cover those learning outcomes. And as was mentioned earlier in this webinar, they're ready to hit the ground running when they get back into their clinic. And so this actually gets logged for hours, work hours, because the aquifer cases are virtual cases. They're logged as virtual cases. So those get logged in XSAT as virtual cases for their family medicine clerkship. And again, we've done this for all of our required rotations. Every rotation has this MRR curriculum incorporating aquifer cases and other modalities. At the end of the week, so they have to write a reflection with practice pearls they've learned from each of the components, including the aquifer cases, and they do a self-assessment exam, which we actually are using UWorld right now. If you're familiar with that resource, it's free right now for the pandemic issues. So they screenshot all of these module completion certificates or whatnot to me in Dropbox, and they're ready to go on to their next MRR. So those are my pearls for use of aquifer.
Thank you so much, Anne. Now I'd like to ask Michelle to share her pearls. And I will say that the three of us and those who use Aquifer use it in many different ways. We're just trying to give you some grab and goes as we're all trying to kind of figure out our new world. So Michelle, take it away.
Okay, can you guys hear me? Okay, perfect. So I'm sorry I can't join you by video, having some unforeseen technical difficulties today. But we've been actually using it in the Thomas Jefferson University PA program Center City campus. We've been using this for the last 2 years. And essentially what I wanted to go over with today was how we utilize those to augment the learning experience within the Skippies themselves, as well as an opportunity to look at our lovely ARCPA standards, which we all love, and see if we can actually hit some of those with aquifer cases. And here is a revelation of what's to come. Yes, we can. So initially what we used in the program for the first year when we introduced Aquifer was really just having an ability for self-directed learning to really just augment those clinical experiences. And then what we realized is as we delved into what Aquifer can actually help us with and what we can pick out of Aquifer is we realized we can actually create our own courses within Aquifer itself. And so just as Anne had said, you can start to then choose specific diagnoses that you want your students to have either the first time seeing or just augmenting again that clinical experience. So you can choose those must-see diagnoses. You can also, and this is where the ARC stuff comes in, is you can choose cases specifically that fit into that acute, chronic, preventive, and emergent settings, as well as choosing cases that nicely fit in to satisfy that care across the lifespan. So for instance, if you are in pediatrics and you happen to be doing inpatient and you're in the middle of RSV season, you see a lot of RSV cases, but you may miss some of the GI cases or something to that effect. So what we essentially did then is created our own courses for each of 5 of our core rotations. So we do it for family medicine, pediatrics, internal medicine, surgery, and behavioral medicine. Each of the cases, this was brought up by Sherilyn in the beginning, has a summary and as well as a synopsis. So it makes it really easy to then figure out, okay, in family medicine, these are all the cases. Let me look at the summary. So this is what's showing up there on the left-hand side, on the bottom of the left-hand side, is you can actually pick those. So you don't have to do the entire case to know if that's one of the ones that you actually want to do. So that's made it really, really helpful to grab the specific cases that we want within our courses. What we do as assessment is a little bit outside of the Aquifer itself, but we choose 10 specific cases for those core rotations, and then we have them write their own synopsis. So it's not a SOAP note. It's actually supposed to help them with, if this is the person you're seeing and you worked through this whole case, give us a synopsis so that it helps you present to your preceptor. So it's hitting a couple of different techniques and skills that we feel are pretty important for our students. Next slide. So here's those ARC standards. So specifically the B303, supervised clinical practice experiences for preventive, emergent, acute, and chronic care across the lifespan, including women's health. So we don't use it for our women's health. We do actually practicals as the assignment for that rotation. But there are, within the family medicine cases in Aquifer, there are also cases related to prenatal care, gynecologic care, and an L&D case, which is really nice too. The surgical management, we use the WISE-MD, that's part of Aquifer, and then certainly behavioral and mental health, we pull those out of family medicine, internal medicine, and pediatrics. So again, Aquifer is great because it has cases that cover all of these care settings. Certainly this isn't the only way that we satisfy our ARC standards, but it certainly helps that this is an additional component that we can say all of our students are standardized to these specific cases that hit all of those buttons. So the left-hand side here has what we've created for pediatrics, and it's not the whole list. We, again, do 10 cases, but just looking at this list, you can see, you know, it's a well-child child visit for 2, 6, 9 months of age. There's a 3-year-old, there's an 8-year-old, there's a 16-year-old. So in the pediatric age group, it has nicely satisfied most of the, or all of the age groups. Next slide. And then I just threw, oops, go back one slide. I just threw up some other examples of what we use. So family medicine, again, you can see that there's certainly some preventive health visits. There's acute visits in many of those. The internal medicine looks at acute and preventive health and chronic disease management too. So it just helps us tick off of those additional ARC buttons. I think Sherilyn was the one that showed this in the main group, but the Aquifer snapshot on the bottom right there, it's very easy actually to create a course, and I know there was a breakout session for that, so I won't get into that, but into great detail. But it allows you to look at that case library pretty quickly, and you can either say, okay, I'm trying to create a course for pediatrics, so you can choose the age group, you could choose the clinical location or the clinical focus, and then what's missing on this screen is on the bottom right, it'll say create course. So you'll get a whole listing. You can again look at those synopsis or the overviews of the case so that when you're picking the cases out, you're getting the right diagnoses in the right setting. And it's really easy to create the courses, and then you just invite your students to that specific course so they work through the cases as they go. And I think that's my last slide.
It is. Okay, so next slide. So I'm going to bring us on home with talking about Journal Club. And we've been doing Journal Club for years. I did it at Quinnipiac for years. But with COVID, we kind of flipped things around a little bit. And so we're using our Journal Club to help us, obviously not our sole source of helping us address B3.03 with types of patient encounters across the lifespan, et cetera, but also with B4.02, the monitoring and documenting progress and clinical reasoning and problem solving abilities. So we changed our Journal Club from a traditional Journal Club with COVID to a Journal Club using Aquifer cases. And what's important is we need to do some prep work, some pre-work, and we like to have that out to our students about 2 weeks in advance. As far as faculty prep, they review rotation assignments in the schedule to determine case selection. So for instance, if we have students in PEDS, we need to find some PEDS cases. IM, we needed an IM case, etc. Then we review the list of Aquifer cases that are available and their diagnoses. And we match the Aquifer cases with the rotation and the RPA clinical standard like setting or lifespan or type of care. And I'll note that in the case synopsis, when Sherilyn showed that, you'll note that it actually tells you the location. So on that one, it had an H for hospital, so you can choose what kind of setting, if it's an inpatient setting, an outpatient setting. So we match it with the RPA clinical standard, and then we also use the NCCPA blueprint for topics. Then we place the students in groups by rotation, and there were about 7 to 9 that are in a group. We assign cases to the cases to the students, and we allow them about 2 weeks for prep. And we also review the articles that are used by Aquifer. So at the end of the synopsis and the summary, it actually gives you the resources, and there are really great articles there. So we choose at least one of those articles, and then we try to identify some other articles that will provide a nice rich discussion, and we provide those to the students. We also gave the students, and I've got it kind of listed, posted at the bottom left-hand corner, we gave them our grading rubric for their Journal Club for COVID, and it gives them the expectations of what they need to look for in the assigned article and the framework of how to approach the article and to critically evaluate it. You'll note on the bottom where it says Aquifer Geriatrics, what I like there is when you go to that kind of catalog, so you see geriatrics, you saw the case number, you see the title, and you can click on it, but to the right, you can just scan quickly, like you can look at the synopsis or you can look at learning objectives. So I had a student who had some bordering on academic integrity issues, and I was determined that they really needed to do some work around that academic integrity is really like patient errors and you know, honesty and ethics in medicine. And so I went through learning objectives and found a number of cases in the high value care course that really related to ethical decisions and honesty and patient safety. And I thought, well, if you're not honest, there are going to be errors and patient safety. And so those learning objectives pop right up for you, so you don't have to read through a whole case to find what you're looking for. And then the case summaries are really nice. Next slide. So after we did that assignment, we gave them their 2 weeks. The actual journal club, we mapped out, we're using about an hour. We think after that, you're going to start to lose them. So in the first 30 minutes, we do journal club case discussion. And so all students, all 7 to 9 students had to prepare, but on that day, a student is chosen by the faculty facilitator to deliver an oral presentation of the case. And then the other students in the group are given the opportunity to add to the oral presentation, and we see that as a form of peer feedback. And then we unpack the case. And the faculty facilitator will ask probing questions like, can you relate this case to cases you've seen in any of your rotations? And then discuss some of the challenges that this case you could see in this case that could arise in clinical practice. And what we found is really got a good, rich discussion, and the students really did connect and reflect on their previous clinical experiences and correlated them with the cases. So we thought that was nice. And then we move on to 30 minutes of article discussion. And the basic structure there is about 15 minutes of going through strengths and weaknesses of the article, then associated readings that we've given them, maybe some other articles that are on the same topic but might have a different viewpoint or opinion. We do that for about 5 minutes. And then we do a discussion for about 5 minutes on application, like how does this article apply to the case? How does this article apply to PA practice? And then in the final 5 minutes, we use that for feedback. So the timing is an hour, and that hour really is contingent on the students completing the pre-work. And you'll know if they haven't, you'll know because it goes down the flusher pretty quickly, and being prepared. And if they are, it's a really nice, rich discussion. As far as assessment goes for Journal Club, we are using our Journal Club grading rubric, which I posted in the corner of the other slide, and that's a group grade, and that's based on case and group presentation. It's based on their case learning objectives, discussion. I don't mean case Western Reserve, I mean the case. Journal article discussion and the journal article strengths, weaknesses, and clinical relevance. And then finally, their group cohesiveness. And then for an individual grade, we're using the students each write a note on the case. Feedback has been really positive from both the students and the faculty facilitators. Student feedback comments included like, I really like the ability to relate the case to cases I've seen in clinicals. It reinforced content from patient cases I've seen. The case was easy to follow and how it unfolds was like an actual patient visit. And then one student actually said, oh, I know, my preceptor uses this article in her practice. So it really does provide, I think, a lot of reality check, and it validates the cases that these are not just made up, that they really do relate to what they've seen clinically and will see in their clinical practice. Faculty feedback was also very positive. Faculty stated, I was surprised how engaged students were, much more engaged than our typical journal club. It was a really collaborative spirit. And this journal club was one of the most rewarding things I've done with the students. So the tools that we're using, we certainly use the Aquifer case learning objectives, and then the Aquifer case summaries are outstanding, and we've all listed them. I've got one in the corner. They're really well done. We use them as a guide as we move through to make sure that we cover each of the learning objectives. It gives us a framework for the discussion, and it provides references from which we can choose the article. So, you know, low-hanging fruit for us. We're all busy having to sit and develop all this on our own when it's right here. It's kind of pack and play for our, you know, plug and play for our faculty, and our students really liked it. I'm going to put a plug in for, again, family medicine, a great course, because as Michelle and Ann mentioned, you get adult medicine, women's health, including obstetrics, peds, and geriatric cases. So if you're on fixed income, I think that's a great product because you get a lot of use out of it. The other is the Wise on Call is really nice. That was developed initially for transition, fourth-year medical students transitioning to residency, and it really does a nice job with big topics like abdominal pain, you know, those kind of big 12 topics that your students need to know, and how to handle on call. Next slide. I'm just going to quickly do a couple other things that we do. So yes, we too use it as remediation. We remediate deficiencies of clinically relevant program learning outcomes like application of knowledge, critical thinking, critical thinking and clinical reasoning skills, and our communication skills. And I'm going to tell you that there is an awesome oral presentations course. My colleague at CASE, Dr. Michael Dell, is one of the developers. It is so great. You can use it in your first year in your communications course. And we all know that students do struggle making oral presentations. So it is a really great course. I highly recommend it. And then we assign the cases related to the clinical rotation, and we urge them to do the embedded self-assessment questions. Then we meet with the student for mediation to review their case. They upload their screenshot of the case completion. They do an oral presentation. They write and submit a summary statement, and we compare it to the expert. And then we review their differential diagnosis. We have them do a screenshot, and you saw those little tabs on the side that they can use, and then they write a note. And we use the educator guides. We also use it for clinical curriculum enhancement. Again, like others, when the rotation volume is low or we've got absences that were unexpected illness by a preceptor, or they announce now they're going on vacation, we assign the Aquifer cases to the students. They upload the screenshot of their completion, they write a note, and then they submit a screenshot of their differential diagnosis, their clinical reasoning, etc. What we're planning to do, our newest one, is to do Journal Club on the road, taking it to the preceptor, is to assign our students a case relevant to the clinical rotation along with a relevant journal article, and we can get that article right from the Journal Club, right from the case, the Aquifer case. And then we're going to encourage our students to engage their preceptor to discuss the case and the journal article and get the preceptor's viewpoint on how they treat similar patients. And for us, we are hoping this creates a safe space learning for the student and a non-threatening environment for the preceptor. And so for me, the Aquifer case will serve as a buffer. I don't know how many of you deal with students where you get the comment, preceptors many times feel threatened, or the student's pimping them, or inevitably the student in front of the patient said, well, how did you pick that? I read that you're supposed to use X and you're using Y. So the case can buffer that, where the student can say, I'm working on this case and they're using XYZ for treatment. What do you think about that? And I see this patient use this. So I think it really is a nice, it's a buffer, and it's a nice transition. So giving safe space learning for the student and for the preceptor. So those are our pearls for clinical integration of Aquifer. So Eileen, you're our hostess with the mostest and moderating our questions. So do we have anything we want to answer here before we go back to our space?
Hi, Cindy. Yeah, we've been answering a lot of questions on the back channel, but we did have a couple that I couldn't answer about your journal club. Mm-hmm. People are wondering if that's a separate course or if that's, part of an existing course, and how the articles get picked for that, who picks them,
sure.
And a little more on how that works.
So Journal Club, so our clinical rotations are broken down to the preceptor evaluation, their EOR exam, and we use Journal Club as a component of grading. So we've been doing Journal Club forever, and we have used that as a component of our grading. So you could integrate that. You could write to ARC-PA and integrate it, but we've always used it as a component. It's like 5% of the grade, but we really wanted to kind of carry through that standard of being able to interpret the medical literature. We do all the scientific piece in our evidence-based medicine course in the didactic phase, but it's really that application, because when they get to clinical, I don't want them going to med bullets. I want them to read an article and understand how to apply that into their clinical practice. So we've always done Journal Club that way.
That's great.
So we just refocused instead of how do we pick the articles? We pick the articles on the case. So at the end of the case, in that summary, they list all the articles and they're all relevant. They update every year, like they have guidelines for treatment of hypertension. So we look to see, what might be a nice guideline, or there might be one that's just interesting or one that's controversial. And then we look for some others as well. And our clinical team does that. Our clinical director and our clinical coordinator do that.
Great. Cindy, another question. Somebody's asking, if a student only spends about 10 to 15 minutes on a case, what do you do? And I will tell you, from the Aquifer side, there is the ability, you can say to the student, you need to reset your case and do it again, and you'll be able to see in the report that it's reset. So that's the technical side. But in terms of the academic side, Cindy, any advice there?
So we do the same thing. We meet with them, ask them why. I mean, that's a good thing. It is safe-spaced learning, but you do get to see how much they do. And, you know, sometimes there is a reason. Other times it was just, yeah, you caught me. And we do have them reset and we have them do it because it's done or not done. So they're not going to get credit. They're not, you know, we assess them. I don't know what Anne and Michelle do. What do you guys do when you check and there's like the 40%, the 10%?
You know, I have not been admonishing them for that. I mean, I feel like it's their loss if they have just had to do that for a case log. If it's for remediation, that's a different story. If they have not remediated effectively, they need to go back and do it again or do something else.
And this room is going to close.
I would agree. Yep.
Sorry, just to warn everyone, this is going to close in 30 seconds and we'll move back. But go ahead and finish. But if you get cut off, I apologize.
Go ahead, Michelle,
No,
it's you.
That's okay. I was just going to say we also don't really admonish them. Most of them, I think, in the past actually used to set it and then walk away a little bit. So they can't do that anymore. But we haven't really run into that issue for many people.
Yeah, on the self-learning, we don't do that, but on assignments, if they had it as an assignment, they need to finish it. All right, I think we're ready to go back to our main session, right?